Mr. Freedman.
My lady, we act for Disability Rights UK, Disability Action Northern Ireland, Disability Wales and Inclusion Scotland. The long-term flaws of the adult social care system were starkly revealed during the pandemic in two extreme ways. Care settings became life-threatening. Care services to sustain everyday basic quality of life were withdrawn. Of those extremities, DPO asks you to consider four matters: knowledge, labour, law and the home. First, knowledge. Most disabled people know something that too much of society remains in denial about: that across the life cycle, we all live in care. We are all being cared for, caring for someone or relying on others to provide care. The quality of the care we need and that we give may be variable, but its importance when it becomes due is universal. Which is why a state that is unresponsive to the human condition to care and be cared for not only lacks resilience, but renders people vulnerable. DPO agree with the various descriptions of the care sector being complex, fragmented and fragile. However, what that language bears the risk of obscuring is that the system has been constructed that way. A SAGE statement in May 2022 confirmed that no UK country can routinely identify who is resident in care homes, who is receiving social care at home, and who works in or visits a care home or a person's home. All the inquiry modules thus far have revealed profound weaknesses in data collection and analysis. But in the care sector, the evidence reveals a system where the recipients of care, the way they live, and the way that many of them died was ignored by design. In this long-tolerated state of known unknowns, central government during the pandemic then allowed care inspectorates to suspend routine inspections. Records relevant to the well-being of disabled people remained unreliable or non-existent. The state of institutionalized ignorance extended to do not resuscitate notices, withdrawal of services, unpaid carers, fatalities, and critical aspects of the labour force. Our second observation is about employed care workers. If anyone is remotely serious about future prevention, then the fatalism over how the virus sped through incessant movement of the workforce between care settings must be shaken off. The hazard arose from the nature of the labour market and pre-pandemic reticence about regulating the market, even though it concerns the protection of life and basic human dignity. The risk of asymptomatic transition was known about early, but the risk of symptomatic transmission was also known about because this exploited workforce on insecure contracts and breadline incomes was too small to meet surplus need. The experts on the Social Care Task Force and the Adult Social Care Directors could not conceive of a system in which staff were compelled to remain in one setting because they knew that the system would collapse. Care homes would go under. People would be abandoned. It was decided that the lesser of evils was hazardous movement of staff. Even if too little too late, the four nations realised the importance of discrete financial incentives. Each of the four made decisions to introduce them. Only in Westminster did the Treasury block the adoption of discrete sick pay and/or lump sum payments. However, none of the four nations contemplated altering the nature of the economy, of temporarily nationalising the labour supply, of moving workers from other sectors into this service, of establishing central and regional directorates that could have drawn on diverse management and other expertise, including the DPO and third sector. £500 payments to the workforce and limited market interventions were never going to expand the labour pool enough to reduce the terrible burden of the unintended risks it carried. The failure now to examine how the state can take command and better integrate the different parts of the system would amount to eyes wide open acceptance that COVID-19's extreme outcomes will be repeated. Our third point is about law. The DPO complain that the very first thing that the government did to plan for disabled people during the pandemic was to legislate to take their rights away. They did this by the modification of the obligations to assess and review care and support needs. But can I add to what was said this morning? Importantly, there was also modification of the duty to meet pre-existing eligible needs as recognised under care and support plans. And provided the local authority could be satisfied that withdrawal did not breach the very high threshold of relevant human rights in this context, which is the severe pain and suffering of inhuman and degrading treatment, or otherwise risk to life, then the withdrawal could be made. And so what Schedule 12 of the Coronavirus Act allowed for was the suspension of care services to meet, for example, needs of basic hygiene, toileting, and social contact for people who needed it for fundamental reasons of well-being in their future. Via the government's guidance documents for the so-called easements, local authorities that suspended their services were required to report the matter for monitoring purposes, which is why one of the most troubling aspects for this module is that only 8 local authorities in England lodged reports to acknowledge that they were operating under the emergency law, and in Scotland, a further 4 by survey admitted to doing so. What that can only mean is that local authorities embarked on mass violations of the law when they reduced vital support, but without invoking the easement provision. You have, my lady, DPO, bereaved families, care providers, and Every Story Matters, all speaking to vastly reduced services across the country and the human toll this took. Some local authorities reduced their services to basic life and limb protection. Social contact services were drastically cut, leaving people with dementia, learning difficulties, and mental ill health totally isolated for long periods. The singular benefit of easements was that the law required reasoned, recorded, and open decision-making about withdrawal of services and disclosure of that fact to central government. But across the system, that is the one thing that local authorities near uniformly appear not to have done. Government then helped to misrepresent the human cost by finding false consolation that only 8 reports were made, rather than taking steps to enforce the law. The result is one of the singularly worst failures of accountability and indeed illegality across the period. Which brings us to our final point. The person that the government primarily imagined when it told people to stay at home was someone who could financially, physically, and logistically afford to stay there. Only in afterthought did it imagine the disabled people who could only do those things with the benefit of care, or the unpaid carer who could not leave the home without leaving a disabled person in jeopardy. Notwithstanding the commitment to human dignity and independent living contained in international human rights law, there is something about our ableist state that cannot conceive of disabled people actually living at home. So when government contemplated social care, it far too often focused on care homes and not domiciliary or supported care settings, PPE, asymptomatic testing, food acquisition, the risk of labour, but also the risk without it. All these things were afterthoughts, grafted onto government responses far later than for hospitals and residential settings, if at all. All of which culminates in the paradox of unpaid carers, who are too often the final afterthought for government. In each of the inquiry's remaining modules, it is going to be reminded that caring, from birth through to grave, is the most valuable commodity in any society. Without it, survival is not possible. The relevance of that to this module is that the capacity of the state to leverage unpaid and very low-paid care in an unaccountable and unregulated way is the core reason why the adult social care system remains fragmented and vulnerable rather than integrated and resilient. It was made that way. And the way it is, including how it makes preventable suffering inevitable, and the way it could be to facilitate caring and being cared for as an essential social value, is above all about choice. Thank you.
Thank you very much indeed, Mr. Freeman. Next, I think, is Ms. Jones. Oh, there you are. Thank you.
My lady, I act for John's campaign, the Patients Association and Care Rights UK. Over the course of the pandemic, our core participant group provided support to thousands of people as they struggled to safeguard the care that they or a loved one needed, as they tried to make sense of the ever-changing rules on whether they could be with the person they loved to give essential care and comfort, and for family carers, as they tried to deal with their feelings of moral distress at being prevented from acting in ways that they knew to be right. But despite the consistent efforts of our core participant group and others, adequate support for people relying on social care was simply not available. Rules were applied inconsistently and inhumanely, oversight mechanisms fell away, and a one-size-fits-all approach to decision-making was taken. Each of these exacerbated the harm and distress suffered by people who draw on care and those who love them. My lady, we think that harm is most likely to be avoided when people are included in the decisions that are made about them, when those with relevant lived experience are listened to and consulted, and when the focus is not on institutions, but on the people those institutions are established to serve. Instead, the stories that our groups heard during the pandemic were of people feeling marginalised, overlooked, neglected, powerless and undervalued. We welcome the publication today of the Every Story Matters record, which contains many of these personal accounts. And to give just two more examples, Doug Pawley, a 47-year-old disabled person living in a care home, has given a statement to the inquiry in which he says that the guidance on leaving care homes seemed to him to be perverse. It made him feel trapped, discriminated against, powerless and isolated. It suggested, he says, a fundamental misunderstanding of the lives of people living in care homes and a failure to consider how their needs and preferences ought to be appropriately balanced against the risks. The lesson that Doug draws from the treatment of people in care homes during the pandemic is, and I quote, "I am expendable. My life will be treated with nothing like the same value and respect as other people's." A similar experience was had by Frances, a 100-year-old who lived in a care home. She said that lockdown was worse than living through the war. "I felt trapped, lonely, depressed and forgotten. For over a year, I only saw my family by appointment, through glass, at a distance. For 65 days, I was isolated in my room with no fresh air, no exercise, and no one to chat to. I felt like a caged animal." My lady, the impact on people living in care homes was profound, and it was also deeply distressing for their loved ones. Frances's daughter, Linda, has said that she felt anger and frustration at the government's ineptitude and disregard of the human rights of residents in care homes. She said, "I believe that the relatives of people in care homes during lockdown will live with a legacy of guilt, anger, hurt, and emotional turmoil that will never be erased." Much of the written evidence that you have received in this module and the personal accounts given so powerfully in the impact video that we watched this morning are testament to the truth of that statement. Similar issues were also faced by people in mental health units, supported living settings, and those receiving care at home. Common to all of them was that unnecessary suffering was caused when decision makers failed to recognise the diversity, humanity, and worth of people who rely on care, and when they failed to include them in the decisions that were made about them. Against that background, my lady, I wish to draw the inquiry's attention to the following 5 issues, which we ask you to have in mind, along with the other issues raised in our opening written submissions, as you take evidence over the coming weeks of hearings. Firstly, a fit-for-purpose social care system must be person-centred in its structure, its focus, and in the way in which care is provided and regulated. This means that blanket policies will never be appropriate. They must at all times be responsive to individual needs and circumstances, and they must ensure compliance with existing legislative duties, which are intended to protect people's human rights and well-being. As Liz Saville-Roberts MP said at a Prime Minister's Questions in January 2022, when discussing her fears for her mother who had dementia, the human rights of disabled people, sick people and the elderly are not fair weather luxuries. But in our experience, my lady, they were treated as such. When we look at the visiting restrictions that were imposed on people in care homes, together with compulsory confinement and periods of isolation that would not be thought acceptable in the penal system, it is clear that there was an inexcusable failure to treat people who rely on care as humans with needs and priorities beyond the narrow aim of infection control. Our second issue is that, as counsel to the inquiry opened with this morning, adult social care is delivered in people's homes, whether that be their family home or a residential setting such as a care home or mental health unit. Decisions about and affecting adult social care should never lose sight of the fact that all of these places are people's homes, and decisions about them should be approached with just as much care and caution as decisions taken about the general population. Politicians showed an understandable desire to impose lockdown conditions on the general population for as short a period as possible, and to permit social mixing again as soon as it could be reintroduced. But the relationships and well-being of people who live in care homes were not given comparable consideration, and the draconian restrictions to which they were subject were unjustifiably maintained long after restrictions on the general population were relaxed. Thirdly, we have particular obligations to people at the end of their lives, to provide them as far as possible with a dignified death and the comfort of their loved ones. That means ensuring proper access to palliative care and welcoming the presence of family members throughout the end-of-life period, which should be interpreted consistently with the CQC and NHS definitions and not limited just to the final hours of someone's life. The failure to ensure at all times that dying people could have those they loved with them was a serious departure from the values that should underpin our care sector, and it's one that has caused deep and enduring guilt and anger. Fourth, my lady, we recognise that unpaid carers are the backbone of the adult social care system. Their numbers swelled during the pandemic, and the burden on them increased as they filled gaps in care created by lockdown restrictions, but they received little recognition and even less practical support. They were sidelined from care teams and excluded from settings from where their loved ones lived, even though they are often the true expert in their needs, and they perform an essential role as advocates and supporters in ensuring the provision of person-centred care. In our view, a formal legal right to a care supporter for everyone using health and care services is now essential. Fifth, proper monitoring and oversight are crucial to ensure safe, high-quality care. The suspension of regulatory inspections at the same time that loved ones and visiting professionals were excluded from settings resulted in a marked deterioration in the quality of care in many places. Susan Lyons describes in her statement to the inquiry how it has subsequently become clear that her daughter Sarah, who lives in a care home for disabled adults, faced significant neglect during the pandemic, being left for hours in incontinence pants, deprived of the one-to-one care that she needs, and left without access to necessary communication aids, resulting in a massive and lasting deterioration in her language and social skills. Hers is just one of many stories like this. My lady, I want to close by drawing your attention to the content of an open Five Nations letter written in March 2021 by John's campaign, together with other allied organisations across the UK and Ireland. They summarised the situation then as follows. After a year of fear, distress, and countless separations, family members from our 5 nations want to reassert the larger picture of what a society should be. Over the months of the pandemic, the deepest ties of love, the things that make us glad to be alive, have been treated as unimportant. Spouses, life partners, parents and children have been treated as inessential to each other. Their wishes have not been considered. Their voices have not been listened to. Residents of care homes have been shut in, and those who love them have been shut out. This is not the society we wish to pass on to the next generation or grow old in ourselves. The test of a democracy is how it gives respect and choice to all of its members, young or old, in health or in sickness. My lady, as that letter underscores, the treatment during the pandemic of those who rely on adult social care does not reflect the values that should guide and underpin our society. The inquiry has the opportunity, through these hearings and your subsequent report, to reassert the larger picture of what a society should be and address what a functioning, person-centred social care system within that society should look like. We hope that the evidence you receive through this module and the recommendations you go on to make will provide a robust basis for the reform that is so urgently necessary, and we look forward to continuing to work with you to achieve that.
Thank you very much indeed, Ms Jones. Ms Weston, my seating plan's gone walkabout. Oh, there you are. Thank you. Are you recording?
My Lady, I appear on behalf of the Frontline Migrant Health Workers Group, together with Annabel Timon of Council, instructed by Joe Latimer of the Public Interest Law Centre. The Frontline group we represent is made up of 3 worker-led organisations: the Independent Workers Group of Great Britain, the United Voices of the World, and Canlungan, all of which are third sector organisations and charities picking up the pieces of a social care system neglected by government. My Lady, these organisations give voice to care workers, the majority of whom are migrants, who look after the most vulnerable people in our society. They provide care in charities, providing supported housing and care to people with learning difficulties. They are also foster carers who support young adults as they age out of the children's social care system, and advice workers helping the disabled access the support they need in a system starved of resources. They work in care homes, respite centres, and they go into people's homes to enable them to live independently. They are agency workers, night and day workers, domestic workers employed in private households, comforting, caring, and performing the very most intimate and personal tasks with respect and sensitivity for the dignity of those for whom they care. Their employment is frequently tied to immigration status, resulting in their being banned from the welfare safety net by a no recourse to public funds condition attached to their visas, or because they are undocumented. My Lady, we're grateful for this opportunity, first, to note that this public inquiry presents our nation with an essential opportunity to shine a forceful light on problems in the social care sector and how they impacted on the pandemic measures. Second, to highlight some of the evidence disclosed by Module 6, and thirdly, to make some brief observations about what Module 6 could achieve. Turning to the evidence that Module 6 has produced so far has been illuminating and damning, but for frontline migrant care workers, unsurprising. Firstly, at the outset of the pandemic, the evidence shows the lack of understanding in central government of how the sector functions and just how fragmented and precarious the sector is. Those in government charged with intervening to protect and support the sector simply didn't have an understanding of the mechanics and variety of funding arrangements for the sector in practice. The self-funded, the local authority funded, the NHS funded, or the increasingly opaque business models, non-profit, profit-led, charitable, and though almost completely diminished, local authority owned. And then there's the delivery of care in both domestic and institutional spaces. And then stretched across this landscape was the equally fragmented and wholly inadequate oversight measures. See, for example, the Dash report on the ineffectiveness of the CQC. In this landscape, the evidence shows that business model matters. My lady, models dependent on artificially cheap and insecure labour have no place in the resilient care sector. The pandemic has taught us that a social care sector which fosters and encourages exploitative and unsafe business practices is a dangerous one for both workers and service users. The inquiry will hear from witnesses such as Professor Shallcross, whose work illuminates the additional risks to service users posed by a care sector driven by profit. Evidence from frontline members includes accounts of working in completely unregulated and so-called black market care homes. Professor Ian Hall, in his statement at paragraph 247, notes anxiety about scapegoating care workers as transmitting the disease because of the lack of understanding in government and in the public that it was not they, but their working conditions which were the problem. He points to a lack of data about the movement of care workers between different care environments. Counsel to the inquiry has rightly highlighted in opening the lack of attention given by government to the domiciliary care sector in its pandemic response. This is reflected in the evidence of domiciliary care workers and their managers. This from Julianne Parkinson, member of the National Association of Care and Support Workers. She says, "At times, I was overwhelmed and bewildered with the amount of guidance we received. I felt that the guidance was tailored towards care homes rather than domiciliary care, and therefore was often not appropriate or even relevant for our line of work. It seemed as if any reference to domiciliary care was only tacked onto guidance that had clearly been designed for care homes and not with us in mind. My lady, it should have been obvious to government that workers with more than one job or care homes reliant on bank and agency staff were vulnerable to the spread of infection, that domiciliary care workers undertaking 20-minute visits house to house would be an issue that needed to be addressed. But the paradox they faced was that government faced, my lady, was that this peripatetic, insecure workforce was the fundamental bedrock of a care system wholly dependent on the cheapest possible labour. Agency workers we represent were unpaid for the time it takes to get between jobs, and domestic workers describe how they were often required to provide care around the clock, without breaks, with no one to speak for them, my lady, out of sight. The problems laid bare by the pandemic could not be solved by short-term firefighting. They were fundamentally related to long-term downward pressure on pay, on the funding settlement between central and local government, and the consequences of trying to outsource this fundamental aspect of our society to a market which at best was poorly understood and at worst wholly subject to the effects of profit extraction. The COVID-19 Social Care Support Task Force recognised this early on in August 2020 and advised government explicitly that it was time to, in inverted commas, kickstart some of the longer-term changes by investing in some urgent infrastructure elements around occupational health, recruitment, retention and pay. But as we learned from Vic Rayner's statement, the government ignored these requests. My lady, Bella Ruiz, Impact a witness on behalf of UVW, recounts how staff members at the care home where they worked would come to work when sick without taking a COVID test. They simply could not afford to do otherwise, my lady. She says, "At this time, everyone got very sick. Some people would say, 'I feel sick. I don't know if it's COVID or not, but I have to pay my bills.' On their part, management weren't really trying to find out if people were sick. They just wanted us to work. They just said, 'If you have COVID, please stay at home,' but they did nothing to make this possible." That care workers were amongst the lowest paid who without financial support might continue to work at risk rather than isolate the fear of loss of income was not only obvious, but was specifically raised at least as early as the 6th of March 2020 in text messages between Mr. Hancock and his team. Perhaps most unconscionably of all, this inadequate pre-pandemic position resulted in bad decisions taken during the pandemic in order to save face. On the 13th of April 2020, minutes of the COVID-19 Strategy Ministerial Group state that a commitment to providing full pay to care workers from day one of sickness would, in inverted commas, cause difficulty for the government, as it would be the first time the government acknowledged that statutory sick pay was not appropriate. The Vivaldi study subsequently proved this to have been a fatal decision, my lady, as empirical evidence of the link between the lack of adequate sick pay and the spread of the virus in care homes emerged during the summer of 2020. Like the TUC and others reporting at the time, the frontline experience is that the money later earmarked for supplementing sick pay simply did not reach the care workers. My lady, I turn to the potential for Module 6 to have real impact on the future of the adult care sector. The frontline group seeks recommendations to ensure that this fundamental lack of resilience in the care sector is recognised, understood and addressed in the public interest. We are an ageing population and change is imperative. Frontline's key suggested recommendations are set out at paragraph 181 of its Rule 9 witness statement, but we briefly flag here the following. An urgent review of the system of sick pay in the UK, my lady. Next, the removal of existing barriers to migrant workers being able to move place of work or employer so that workers can challenge exploitative conditions or leave workplaces where they exist and easily switch to other employment. Thirdly, a review of the hostile environment approach to immigration control is also essential. Fostering a system of reliance on very low-paid, undocumented workers wards them away from essential public services, my lady, like vaccination and healthcare. My lady, trust in health professionals is paramount to ensuring that people take appropriate steps to stop the spread of disease and ensuring that misinformation is quashed. So care workers must be able to report poor practice and wrongdoing without worrying about their own job security or their consequent ability to remain in the country for migrant care workers with visas tied to their employment. We ask the inquiry to recommend the implementation of a firewall which prevents data sharing between public authorities, public bodies contacted for assistance in the Home Office, end the criminalisation of working while undocumented, and support safe reporting pathways to work inspectorates, immigration enforcement and the police. My lady, to finish, the government must acknowledge, understand and address the clear adverse implications of such an insecure and exploited workforce for the success or failure of pandemic protections for the most vulnerable, both in care homes and the community. Business models dependent on artificially cheap and insecure labour have no place in the resilient care sector. Lastly, there must be acknowledgement of the value to all of us of the vital work done by migrant care workers during the pandemic. They were disproportionately affected by the virus, disproportionately affected by the follow-on implications. My lady, a workforce as important as this must never be left so unprotected again. My lady, on behalf of Frontline, those are my submissions.
Thank you very much, Ms Weston. Very grateful. Mr Pater. Oh, there you are.
My lady.
Thank you.
The National Association of Care and Support Workers, NACAS, was established in 2016 as an independent professional body to advocate for care and support professionals, promote their value, and provide them with crucial support and resources. Before NACAS, there was no dedicated professional voice for care professionals. Its 15,000 members work across the entire spectrum of adult social care, from care homes to home care, whether employed, self-employed, or on 0 hours contracts. NACAS is grateful for this opportunity to assist Module 6 of your inquiry, particularly through the evidence from its chair, Paul Featherston, which is underpinned by surveys and accounts from its diverse membership. The role of this inquiry in shaping the future of adult social care, including how it responds to future pandemics, cannot be overstated. Care work has been historically undervalued by politics and society, often rooted in its association with gendered roles, older people, and the persistent false view that it is unskilled and economically unproductive. This lack of care defined both pre-pandemic preparedness and the initial pandemic response in the adult social care sector. As Catherine Williams of the Association of Directors of Adult Social Services eloquently put it, there is a collective hope that the inquiry will make a mark in recognising just how essential social care is for all of our lives and start to build a new social contract about how we live, work and care for each other. My lady, to truly understand the pandemic's impact one must grasp what it means to be a care professional. As Mr. Featherstone reflected in preparing our written submissions, he said, "Being a care professional is a privilege that few fully understand unless they have experienced it firsthand. It is an honour to be entrusted with someone's care, to be allowed into their home and their life in such an intimate and essential way. It goes beyond the traditional sense of just providing support or fulfilling duties. It is about forming a bond, building trust, and offering a sense of independence, no matter the limitations that exist due to age, illness, or disability. But that challenge is what makes it so rewarding. There is an inherent growth that comes with this work, personal growth, that stretches you beyond what you thought you were capable of. You learn to be patient, to be present, to find solutions in difficult situations. You learn to read people's needs without words, to comfort with actions, to support with empathy. Being a carer also meant being an advocate, someone who ensures the person you care for has access to services and resources they need. It can feel like a fight at times, advocating for their rights, navigating systems that can be complex and overwhelming. Yet in these moments, you realise the true impact you're making, not just in individual lives, but in the broader landscape of care and support. The role of a carer can often feel like it goes unnoticed by society. It is often the silent work, the behind-the-scenes care that is rarely recognised or celebrated. Yet it is one of the most essential roles in any community. We become the quiet backbone, holding up families, supporting health systems, and ensuring that people can live with dignity. The privilege of being a carer is not just in what you do for someone else, but in what they do for you. They teach you compassion, resilience, and the true meaning of selflessness. They show you how to live fully, even when life is difficult. They remind you of the power of presence, of human connection, and of what it means to truly care. My lady, that inherent sense of duty and commitment was the very foundation upon which the adult social care sector relied, even more acutely during the pandemic. And my lady, as you have heard, care professionals are often vulnerable. The overwhelming majority, 83%, are women. Individuals from global majority backgrounds and migrant workers are significantly overrepresented. 1 in 5 live in poverty, and many earn less than the real living wage. Domiciliary carers often earn less than the statutory minimum wage when travel time and fuel costs are considered. It was on this precarious foundation that care professionals suffered the terrible impact of COVID-19, with existing inequality severely exacerbated. They witnessed the traumatic deaths of colleagues and those for whom they cared. The ONS analysis shows that the mortality rate for social care professionals was the highest by occupation in the UK, 2 to 2.5 times larger than the general population, with even higher risks for staff from global majority backgrounds. Care professionals toiled with staff shortages, a lack of PPE, inadequate testing, confusing guidelines, and limited political and societal recognition, with little mental health support. As NACAS members reported in their own words, my lady, I felt like I was having a mental breakdown from all the stress and worry. Staff were overworked, not having breaks, working extra and double shifts made to cover larger areas and not given the time they needed with the client. Staff were completely mentally and physically exhausted. Some were crashing cars, falling asleep at the wheel. I've never seen deaths like that in my life. COVID made me feel helpless, fearing for my life. My lady, we invite the inquiry to recognise the immense sacrifices made by care professionals and their incredible resilience in continuing to deliver high-quality care under the most adverse conditions. A core reason for the sector's precarious state was inadequate workforce capacity. That is a direct result of structural issues: low pay, poor working conditions, unmanageable workloads, a lack of status, and limited opportunity for training and progression. Pre-pandemic, the sector faced a 7.8% vacancy rate, about 122,000 places, and a 30.8% staff turnover rate annually. By March 2022, vacancies had soared to an unprecedented 10.7%, equating to 165,000 positions. That is an ongoing workforce crisis that has been exacerbated by a long period of austerity. The structure of the sector significantly impacted the pandemic response too. As you have heard, it is large, complex, fragmented, and, for the most part, unintegrated with health services. Consequently, when the pandemic arrived, it was not clear who was responsible for different aspects of the response in adult social care, hindering coordinated action, and meaning there were very few levers available to drive change at scale. Crucially, my lady, you may find that central government demonstrated a troubling lack of understanding of the sector. Sky has observed that the government's understanding of the sector's readiness, capacity, and capability appears to be incomplete, poorly understood, or overlooked. This led to a delay in addressing adult social care concerns, particularly as compared to the NHS. A striking example being procurement officials expressing disbelief that 4 million aprons would be needed daily for social care, failing to even grasp the sheer size of the 1.6 million strong workforce. My lady, the inquiry is invited to investigate the root causes of that lack of understanding, which the evidence suggests could include a lack of institutional knowledge, insufficient reliable data, the misperception of adult social care as merely an adjunct to the NHS, and the exclusion of adult social care voices from key decision-making. And on that latter point, my lady, there was a complete absence of adult social care voices when critical early decisions were made. There was no dedicated Director General for Adult Social Care until June 2020, and no adult social care voice in SAGE until mid-2020. That exclusion meant that adult social care was invisible, and key decisions were made without adequate consideration of their impact on the sector. Decisions that were made were often characterised by inaction, delay, and fatal misjudgments. And we draw your attention, my lady, to 4 issues of particular concern to NACAS members. First, flawed guidance. The February 2022 Adult Social Care Guidance, published by PHE, was fundamentally flawed. It, in short, advised business as usual. It stated it was, quote, very unlikely that anyone receiving care will become infected, that face masks do not need to be worn by staff, and there is no need to do anything differently. That guidance remained in effect until the 13th of March, effectively lulling the sector and its staff into a false sense of security during a critical window, despite evidence of asymptomatic transmission emerging as early as January and February of that year. It, my lady, set the tone for the guidance that followed, which was often issued too late, lacked specificity, was frequently inapplicable and contradictory, and updated so often that the sector struggled to keep pace. Second, the hospital discharge policy. The policy to discharge patients from hospitals to release capacity in the NHS, while understandable in its aim, was, you may find, emblematic of an over-focus on the NHS at the expense of adult social care. Care homes overwhelmingly felt pressured to accept discharged patients without knowing their infection status. The lack of planning and consultation meant that adult social care was not prepared to manage the increased demand and risks. The evidence, including the Vivaldi study, clearly shows the policy was a source of ingress into care homes. Attempts by some to divert responsibility to care professionals, attempts that have been stripped of the context of the misleading advice that was given to the sector, have been deeply damaging, leading to abuse, discrimination, and feelings of being degraded among NACAS members. Third, my lady, testing and PPE provision. The adult social care, particularly domiciliary care, was forgotten about or deprioritised for PPE distribution and testing. At the pandemic's outset, confusion reigned within government over who was responsible for the supply to the adult social care sector, leading to the NHS and the sector competing for the same supplies. PPE that the social care sector would have sourced for itself was even diverted to the NHS, leaving the sector feeling like an afterthought. This left care workers insecure, vulnerable, and forced to rely on donations or makeshift items. The lack of suitable PPE and testing may explain, in part at least, the disproportionate morbidity and mortality rates for care professionals. Fourth, my lady, mandatory vaccination. This policy, introduced in July 2021, mandating vaccination for adult social care professionals in England in care homes was, you may conclude, unnecessary, unfair, and ultimately counterproductive. It was not adopted by devolved nations, did not apply to health workers, and ignored widespread concerns across the sector. The government's own risk assessment estimated 40,000 staff might leave their posts. At the point it was revoked, 19,000 professionals were estimated to have lost their jobs, further exacerbating the severe staff shortages in the sector. And the policy disproportionately affected women and individuals from global majority backgrounds and may have undermined wider vaccination support. My lady, finally, NACAS extends an invitation to the inquiry to consider an important potential recommendation throughout the evidence. That is, achieving parity of esteem between the adult social care sector and the NHS, including through the professionalisation of care work. The Nuffield Trust has identified a growing interest in professionalisation as a solution to the workforce shortages. Registration and adherence to common professional standards would create a strong professional identity, attract new entrants, and encourage retention by offering career progression. England is unique in the UK for lacking a professional body responsible for regulating social care workers that is mandated and accountable to government. Examples from the devolved nation show clear benefits, increased knowledge of the workforce, improved retention, and a positive impact on the quality of care and confidence among both workers and service units. NACAS believes that recognising the complex reality of care work, addressing systemic vulnerabilities and embracing the professionalisation of the care workforce are vital steps towards building a resilient, valued and effective sector ready to respond to a future pandemic. Thank you, my lady.
Thank you, Mr. Pater. Professor Rayner.
My lady, this is the opening statement of the National Care Forum, and I am its Chief Executive. The National Care Forum is the membership body for not-for-profit care and support providers in England, who provide a diversity of services across all age groups. Including residential and nursing homes, supported living, extra care housing, domiciliary care and day services to hundreds and thousands of people. The National Care Forum dedicated significant time and resources throughout the pandemic to support and represent the experience of its members, highlighting the operational realities of delivering social care and support and how they related to government guidance, engaging with the government and other stakeholders and advocating on members' behalf as they battled COVID-19. My lady, before I go further, I want to acknowledge the loss of life of all those with a connection to adult social care, including people accessing care and support and care workers. Care workers, people accessing care and support, their families and loved ones were all deeply impacted, and in addition, many continue to grapple with ill health and the legacy of those years. In this opening statement, I want to give voice to the myriad of ways in which social care providers supported communities and their most vulnerable citizens to ensure their care and support needs were met. In the face of huge challenges, I want to highlight the isolation and systemic misunderstanding and disadvantage that the adult social care sector experienced repeatedly throughout the pandemic. I also want to be clear that the UK government did, in fact, receive a huge volume of information and expertise that NCF and our members provided repeatedly directly from the front line of delivery, which highlighted in real time the risks facing social care and support services and what was needed to minimise, where possible, their impact. We are also concerned that much of what the inquiry has heard to date does not adequately recognise the skill, professionalism and dedication of the social care workforce, particularly in the face of the pandemic. The response of adult social care and support providers in the face of limited resources, limited support from wider system partners and increasing restrictions was only possible because the people who make up social care, the frontline staff, the managers, the support team, the senior leaders, alongside many others, all came together to find a way through and deliver care and support. Many took on jobs and activities they wouldn't normally do. Everyone was working together to ensure that quality care and support was maintained. And they did this because social care is inherently relational. It is about supporting people. They did this because they care. This is vitally important for the inquiry to hear. My lady, I want to use the remainder of the ongoing statement to outline significant concerns we had with regard to the impact of the pandemic on the adult social care and support sector and the key decisions made by the UK government during that period which made the response more difficult. These are more fully laid out in my witness statement. I first want to highlight pre-pandemic preparedness. While outside the timescales of this module, it is important for the inquiry to remember that social care went into the pandemic ill-prepared, with over 100,000 staff vacancies, a precarious financial situation following a decade of austerity, and the lack of any investment by the state in digital, data and physical infrastructure. The risks around capacity were highlighted as urgent as recently as 2016 during exercise Cygnus. Second, throughout the pandemic response, there was a concerning lack of understanding of adult social care by policymakers, leading to an unhelpfully narrow public, policy and resource focus on care homes for older people, with little consideration of the breadth and diversity of care and support settings and services, which all needed a help and start from the start of the pandemic. As a direct consequence, guidance and policy created during the pandemic were marked by a lack of understanding of the diversity of adult social care and support services and the people using those services. The flow and communication of guidance from government and key stakeholders were poor and chaotic, and this was exacerbated by unclear chains of command, particularly the role of national versus local decision makers. Changes in the guidance itself were often communicated last minute, sometimes over bank holidays and often late on Friday nights. Changes in the policy relating to key elements of social care and support were often communicated by press release or the daily briefings, with this landing sometimes days and occasionally weeks before the final guidance was issued, leading to a mismatch between public understanding of the situation and the guidance that care and support providers were being instructed to follow. All organisations had to grapple with multiple, interdependent, sometimes contradictory pieces of guidance, which were updated at different times. This was particularly challenging for smaller providers who form the bulk of the adult social care sector. I want to move on to the disregard shown for the people accessing or working in care and support from government and the wider health system in relation to key areas including testing, PPE, vaccination, accessing of community and specialist health services, and many other areas. The advice of social care experts was often ignored or marginalised. This is in spite of repeatedly highlighting key issues including the breadth and depth of social care and support, the need to ensure that guidance was possible to implement for small organisations, the inability to access community health services and the impact on those receiving care and support and the care workforce, the inappropriateness of blanket guidance around areas such as isolating people living with dementia or other complex needs, the need to balance the risk of harm from COVID through enabling visiting with the risks of harm resulting from separation and isolation from loved ones, and many more key issues. To support these perspectives, we gathered and shared rapid evidence, sought out independent expertise and provided examples of how to mitigate risks, always building on the critical stream of information we receive day in, day out from the front line through our close work with members. I also want to draw the inquiry's attention to the funding of social care during the pandemic. The drip feeding of funding support was unhelpful, insufficient, inefficient and bureaucratic. Whilst all funding was greatly needed, it came after very significant advocacy from the sector and was provided only in the form of emergency, short-term, time-limited funding, which was never sufficient to meet the publicly described need. This short-termism meant providers were unable to put long-term protective measures in place. My next point relates to the collection and use of data, which was highly problematic throughout the pandemic for adult social care. Infrastructure around data was lacking before the pandemic. And during the pandemic, data collected from providers via Capacity Tracker was used to meet policy aims, such as the freeing up of hospital beds, rather than to prioritise resources for providers who were including data that showcased their lack of PPE and shortages of staffing. In addition, collective data received by government in relation to new variants of data that would have flagged the need for additional capacity was not shared with providers. It is important to recognise that staffing and capacity became increasingly difficult due to the direct impact of the pandemic, with organisations dealing with rapid increases in vacancies and sickness levels. This was compounded by guidance which required isolation but came without sufficient financial support. In addition, specific cross-sector recommendations relating to the social care workforce in the summer of 2020 were not adequately addressed by the government. Finally, the pandemic has revealed the deep-seated inequalities in our health and social care system. Due to its composition and the people who access care and support, this is a sector where several inequalities intersect along ethnic, gender, age, disability and socio-economic lines. My lady, as outlined earlier, this will only change if the apparatus of government actually understands and values the people who work in social care and the lives of people who receive care and support. In conclusion, the points I have outlined can be summed up in 3 ways. Number 1, social care was overlooked in key decision-making moments. Number 2, social care was misunderstood by decision makers and the wider public. Social care is a diverse, interconnected system of care and support services for all ages, with a workforce larger than the NHS. Number 3, social care was disadvantaged, especially in comparison to the NHS. The focus of decision-making appeared to be narrowly on protecting NHS hospital capacity rather than citizens in all communities. Our participation in the inquiry is motivated by our commitment to ensuring that everyone involved in care and support does not have to go through this experience again. It is essential that clear operational and implementational lessons are learned and applied across pandemic planning, preparedness and response. Those are our opening submissions, my lady.
Thank you very much indeed, Professor Rayner. Dr. Townsend.
My lady, I appear on behalf of the Home Care Association, the only UK body that speaks exclusively for providers of home care, also called domiciliary care. I'm grateful for the opportunity to assist the inquiry and through it, the bereaved families, people who draw on care, and the dedicated workforce who supported them. At any one time across the UK, about 1 million adults rely on professional home care, more than double the number in care homes. Around 6 million more receive informal unpaid care, and a further 2 million have unmet care needs. That's at least 9 million people needing or receiving support at home, compared with just over 500,000 in hospitals and care homes. Yet public attention and resources have often focused elsewhere. There are some 740,000 professional home care workers in England alone, more than the 698,000 in care homes, delivering support in ordinary homes across every community. They help people live well at home, uphold rights, prevent hospital admissions, and enable safe discharge. But before, during, and after the pandemic, home-based care was often invisible in policy, data, and debate. Our evidence reinforces what my colleague Rayner has just said. There are 3 overarching themes. First, home care was overlooked in key decisions. Ministers and officials focused on protecting the NHS and later care homes with insufficient awareness of the scale and importance of care delivered behind closed doors. Second, home care was misunderstood. Decision makers treated social care as synonymous with residential care for older people, overlooking the diversity and complexity of services delivered at home. Third, home care was disadvantaged compared to the NHS and care homes. Access to PPE, testing, vaccines, data, guidance, funding, and professional respect all lagged behind. The pandemic exposed a number of structural weaknesses, and I draw your attention to 5. First, fragile foundations. Years of underfunding and insecure commissioning left home care providers without reserves. COVID-19 related costs added about 25% to hourly delivery costs, while fee rates barely changed. Funding intended to keep the sector going often failed to reach home care. Lack of leadership and expertise. Social care, and especially home care, was largely absent from SAGE, COBRA and ministerial briefings. It took over a year for a SAGE social care working group to appear on any public list. These blind spots cost lives. Reduced access to other professionals. National instructions to minimise face-to-face contact led many professionals, GPs, district nurses, social workers, housing teams and regulators to withdraw to remote working. Home care workers were often the only professionals entering homes, sometimes asked to carry out tasks such as wound care, insulin injections, verification of death, without adequate support. One provider told us a district nurse threw dressings over the threshold and ran away. Poor communication and lack of data. There was a paucity of official data about home care and no reliable national channel to reach all home care providers, making coordination nearly impossible. And deep-rooted inequalities. The largely female, ethnically diverse, low-paid workforce received little sick pay protection. Some had to choose between infection control and paying the rent. The practical consequences were severe. Access to healthcare was restricted. The message to stay at home, protect the NHS, save lives, led many to delay or avoid seeking help. While only 7% of deaths at home were officially attributed to COVID-19, by mid-2022, hospital deaths from non-COVID conditions had fallen by over 100,000, while deaths at home from causes like dementia and cancer soared. PPE and testing were hard to access. 8 in 10 home care providers could not secure PPE in April 2020. Business as usual orders paid for by home care providers were diverted to the NHS. Workers fashioned makeshift protection from fabric and bin bags, while government guidance said they didn't need it. Routine asymptomatic testing for home care staff only began in January 2021, 10 months after it started in the NHS. People were transferred from hospital without tests, transferring risk and responsibility to families and home care workers. Vaccination saved lives, but the policy to make it a condition of deployment risked them. It threatened to remove up to a fifth of an irreplaceable workforce at the height of staff shortages. Around 18,700 workers left the sector in anticipation before the policy was withdrawn. Emergency funding was distributed inequitably. At least 75% of the first infection control fund went to care homes. Home care received the scraps under the table. Funds were often denied to providers without council contracts, excluding many who delivered NHS-commissioned care or self-funded care. Some councils, like Hertfordshire, distributed funds equitably to all providers, but this was the exception. Movement restrictions were unworkable. Home care, by its nature, involves workers moving between households. Restricting this would have required far more staff, at a time when vacancies were 4 times higher than the wider economy and staff turnover already exceeded 25%. Other countries used cohorting, enhanced PPE and testing rather than blanket restrictions. Guidance was chaotic. Initial advice claimed community transmission was low and masks increased risk. Neither was true. Guidance changed frequently, often late on Fridays and without adequate consultation. One flawed instruction in September 2020 forced providers to scrap vinyl gloves overnight for scarce nitrile stock. It was reversed weeks later after confusion and cost. There was a regulatory vacuum. The Care Quality Commission paused inspections. This left home care providers without oversight and people without assurance. Some services have still not been inspected for more than 7 years. The human cost of the pandemic was devastating. Thousands became isolated with deteriorating health and no access to essential care. Those receiving professional home care fared better because care workers became their advocates, lifelines, and sometimes their only human contact. Care workers made difficult judgments alone and often were the only people present to comfort someone at the end of life. Families rightly ask, whose lives did the government intend to save when those most at risk could not access the healthcare they needed? The inquiry can help future responses are fair, effective and inclusive. We urge the inquiry to recommend embedding social care expertise at every level of emergency planning, science advice and operational command, creating a standing national social care forum with equal status to the NHS, guaranteeing equal access to PPE, testing, vaccines and sick pay across health and social care, requiring integrated community services, including continued face-to-face input from GPs and district nurses, supported by safe PPE and clear protocols, building a modern data infrastructure that captures everyone receiving or delivering home care, valuing and protecting the workforce with sustainable funding that supports fair pay, training, technology and resilience, ensuring emergency funding reaches all providers automatically and equitably, and developing policy, especially for home care, recognising its distinct nature from residential care. As I close, it is important the inquiry recognises that during lockdowns, many home care workers walked through silent streets before dawn, so people at particular risk could live safely and with dignity in their own homes. They filled the vacuum left by others, sometimes at cost to their own health or lives. Their courage steadied the nation. We owe it to them and to those they served to build a system that will never again leave people unseen and unsupported. I stand ready to assist the inquiry further. Thank you, my lady.
Thank you very much indeed for your help, Dr. Townsend. I think we'll break now and return at past, please. All rise. Ms Jacobs.
My lady, these are the submissions of the Trades Union Congress. I'm instructed by Thompson Solicitors and I appear with Miss Ruby Peacock and Miss Natalie Lucas. In these opening submissions, we focus on the experience of those who worked in the pandemic in adult social care. The social care sector is, at its core, a social care workforce, a cast of many thousands who provide care and support, and in many cases a home and company and companionship for those who depend on the sector. Undoubtedly, working during the pandemic in adult social care was, for many, a traumatic experience. We are grateful to Miss Carey King's Counsel this morning for recounting the experiences of Miss Kitchen, a wellbeing coordinator who covered care shifts in a residential home. The experiences she described of caring for large numbers of COVID-positive patients, providing end-of-life care and managing end-of-life meetings with family members over Zoom were traumatic but common. The account of the distress of not being able to hug family members who themselves felt like extended family gives an insight into the value of care work, which is often so inadequately reflected in pay and conditions of work. My lady, this was the trauma of an already beleaguered and vulnerable workforce. It is a workforce which, as we have heard, depends on a high proportion of migrant workers who face additional vulnerabilities and a significant proportion of Black, Asian and minority ethnic workers. The challenges for workers of proximity to death and exposure to a novel virus were exacerbated in myriad ways by some of the structural issues faced by the sector. There were common experiences for social care workers of not only a lack of PPE, but a sense of being at the very back of the queue, of generally being a low priority, a mere adjunct to the NHS, of working in an environment that felt essentially hidden from central government and from regulators, of not being able to self-isolate without significant financial difficulty, of feeling abandoned with terribly unwell residents in pain without being able to bring in and lean on proper medical expertise and treatment, of working amidst staff shortages and the pressure to cover more and more shifts at the expense of personal well-being, of not being able to raise concerns about poor health and safety because of being in precarious employment. My lady, that latter concern was reflected so powerfully in the impact film this morning, the account of workers not being able to raise concerns for fear of losing their jobs. When we talk in general terms of precarious work, it is these sorts of difficulties which are the lived realities which result, to the detriment of the safety of those who provide adult social care and those who depend on it. And we wholeheartedly endorse the observations made before the adjournment by the Frontline Migrant Workers Group and others about an exploited workforce. My lady, as to the state of the social care sector and these structural difficulties, you will not find a single witness before you who says anything other than that the system of adult social care going into the pandemic was under-resourced, fragmented, and generally neglected. That those are the characteristics of social care is not sensibly an issue. It has been examined to a point in Module 1, and the Department of Health and Social Care in its own opening written submissions does not shy away from those features. And it is not surprising that in the opening statements today, some core themes have emerged. It begs the question, my lady, what to do with a problem like adult social care. There would appear to be a risk that inquiry calls for change merely sit atop an already large and dusty pile of reviews and committee reports, which have, over many years, realistically, called for change in the structures of adult social care. But a justified fear as to the prospect of change simply makes it all the more important that this inquiry sets out the issues in the barest and starkest of terms. This inquiry cannot itself devise the national systems necessary to support the operation of adult social care, but it can set out what such national systems should be able to achieve in order that the response in the next pandemic can be more effective. A central point must be strategic action on the social care workforce. The sector came into the pandemic with 120,000 vacancies and high staff turnover. For reasons we and others have touched on, it is not just a question of numbers of workers, it is a question of the conditions of work. Some of the features of precarious work, of not having the financial support to stay away from work when ill, of working various shifts across various homes, and of vulnerability to unsafe working practices, need to be addressed. It needs ultimately to be a more valued, better paid, and less insecure workforce. Some action was taken by way of the May 2020 Infection Control Fund, but the lack of structure for oversight of the operation of the sector meant that it was, in substance, an expenditure with little sense of where the fund actually went. Minutes of a COVID-0 meeting in December 2020 state, quote, "The fund was designed to support the restriction of movement of staff between care homes, but its weak processes meant that funding was not reaching those who needed it most." Evidence disclosed to this inquiry demonstrates that in October 2020, only 25% of employers were paying staff who needed to self-isolate their full wages. Some homes had refused to sign up to the fund because they feared setting a precedent of paying full sick pay beyond the pandemic. It also shows that the Department of Health and Social Care did not have the ability to check whether care home staff who tested positive in the weekly testing programme were being paid their full wages. PPE and preparedness, over which there must be some national operational oversight, needs to be transformed. A poll carried out by Survation on behalf of GMB in April 2020 found that fewer than half of social care workers felt that they had been provided with adequate PPE. Contributing to unsafe working conditions was an absence of effective regulation in the sector during the pandemic, and we echo what has been said on that by others. Essentially, the lesson should be that amidst the dangers of a pandemic, regulators should step not back but forward and assist in ensuring the safety of those who depend on and work in social care. And you have heard accounts this morning which make clear that regulatory input can be supportive. The policy of vaccination as a condition of deployment was especially distressing for social care workers, and it compounded the effects of structural racism and worsened the understaffing crisis. Workers described to the TUC the vaccine mandate as being pressurised, forced, like blackmail. A residential care worker in the north of England describes it felt like a betrayal, like we were useless and incapable of keeping the people we support safe. What the TUC says is that more ought to have been done to build trust and share information about the vaccine. A survey by the TUC in Unison found that 58% of social care workers reported not being provided with enough information about the vaccine. My lady, these are some of the important issues to be considered in this module. They are important in shedding light on and improving the position not only of those reliant on adult social care, but those who provide it. They are workers who continue to provide care during the pandemic at great sacrifice, and they are owed the careful and robust consideration of this inquiry. My lady, thank you.
Thank you very much indeed, Mr. Jacobs. Mr. Boyle.
My lady, as you know, the Royal College of Nursing is the representative voice of nursing across the 4 nations of the United Kingdom.
Can we just check the usher's coming to help?
There you go. It's on now. I'll begin again. My lady, as you know, the Royal College of Nursing is the representative voice of nursing across the 4 nations of the United Kingdom. It is the largest professional union of nursing staff in the world. It has more than 500,000 registered members, including nurses, student nurses, midwives, nursing support workers, and healthcare associates. The Royal College's members work not just in NHS hospitals, but also and significantly, for the purposes of this module, in specialist health facilities, in care and nursing homes, in the community, visiting patients in their own homes or the homes they share with their loved ones, and in the independent healthcare sector. Given the extent of its membership and the extraordinary breadth of the experience which its members have across the adult social care sector, the Royal College hopes and is in fact confident that you, my lady, will factor into your work through this module and ultimately your recommendations the voice of the Royal College on behalf of its members. The written and oral testimony of the Reverend Charlotte Hudd and Claire Sutton will hopefully assist you in that regard. Regrettably, and perhaps surprisingly, given the breadth of its expertise and the experience it can call upon, the voice of the Royal College has not always been welcomed, listened to, or engaged with by those in power. You have our written opening, so I propose to address you briefly under 3 headings. Firstly, workplace capacity, staffing shortages and underinvestment. Secondly, disparity of treatment between social care in the community and the NHS. And thirdly, the impact of the pandemic on nurses and care workers in adult social care. First topic then, workplace capacity, as to which you've heard a good deal already. Years of underinvestment in community care and the care home sectors meant that adult social care was left exposed when the pandemic hit. The Royal College had consistently highlighted over a number of years the absence of effective workforce planning for nursing. The impact of this failing was already manifesting itself pre-pandemic and endures to this day in high levels of vacant posts and escalating expenditure on agency staff. The failure of the UK government to tackle the issues facing the nursing workforce, including in recruitment, retention and burnout, remains a serious risk to the country's ability to robustly tackle future pandemics. Currently, in England, there is not yet a credible system for understanding workforce shortages and responding to increasing demands in both population and service. Persistent systemic workforce issues and underinvestment put nursing staff and patients at risk. Over 5 years on, the adult social care system remains fragile, as counsel to the inquiry described it earlier. That is alarming. The Royal College is calling for a strong legislative underpinning of government accountability for workforce planning and supply across health and social care. In England and Northern Ireland, there is no law related to nurse staffing, unlike the Nurse Staffing Wales Act of 2016 and the Health and Care Staffing Scotland Act of 2019. The College is calling for legislation in each UK country to guarantee nurse staffing levels across all sectors and settings. Put simply, nursing should no longer be viewed as a cost burden, rather a profession, a workforce to be invested in and valued for the benefit of us all. Second topic, disparity of treatment between social care in the community and the NHS. Historically, there has been an artificial and unhelpful divide between adult social care and the NHS, with unequal access to resources, guidance and workforce. This had led to an unfair perception that adult social care was in some ways secondary to or less important than acute hospital care. The description by Mr. Weatherby KC from one of the witnesses of the government's not knowing how many care homes were in existence is an example par excellence of that disparity. This perception appeared to continue throughout the pandemic, with care homes feeling under pressure to take untested, discharged patients, and as you heard from the impact video, on occasion, those who had in fact tested positive. And that to prevent the NHS from being overwhelmed, but which ultimately may have resulted in higher levels of deaths in care homes than would otherwise have been the case. We have all watched the damaging and long-lasting impact of that from the moving accounts of relatives in the presentation at the commencement of this session. The inadequacies in the management of the discharge processes were then compounded by the inadequacy and lack of availability of PPE for staff in the social care setting, which in turn was coupled with the comparative lack of availability of testing in social care facilities as compared to larger NHS facilities. Throughout the pandemic, the Royal College conducted a number of surveys where members repeatedly reported that perfect storm of inadequacy and disparity across the health and social care sector. In terms of infection prevention and control, as a profession, health and social care workers deliver the vast majority of physical and psychological care to patients in all care settings. Over the years, they have led the way in reducing the transmission of infection by prioritising IPC measures in their clinical practice. These measures are fundamental to the safety and well-being of the profession and the patients. The Royal College and its members is uniquely placed to understand the importance of IPC methods to reduce the spread of infection and, in so doing, to protect patients from avoidable harm. It was extremely disappointing that the voice of nursing was absent from discussions regarding the creation of IPC guidance for the care sector. The Royal College invites you, my lady, to recommend that nurses need to be engaged with and play a significant role to help shape and influence policy for the provision of social care and its guidance that affects the communities they care for. Final topic, impact on nurses and care workers. The concerns which the Royal College has to ensure there is future-proofing of suitably resourced and equipped staff working in safe environments in adult social care are real, given the impact the pandemic has had on the physical and mental health of so many of its members. Many lost their lives just by turning up for work. Many lost their careers through the impact of the pandemic on their mental health. Many continue to suffer the effects of long COVID, which has blighted their ability to work and perform the public service which they so cherish and which our society so desperately needs. These consequences and the inevitable impact on the safety of those they care for should never happen again. And the Royal College, my lady, as has been the case in other modules, stands ready to assist this inquiry to try to achieve that aim.
Thank you very much indeed, Mr. Boyle. Mr. Allen.
Good afternoon, my lady. As you know, as in other modules, I represent the interests of the Local Government Association and also the Welsh Local Government Association. The two associations work very closely together and welcome the opportunity again to be core participants in this module. Together, they represent the collected voice of local government, with 100% of the Welsh authorities and over 99% of the English principal local authorities as members. The two associations have a role in ensuring communication between government in England and Wales and their members, the local authorities, who have the statutory duties in care, slightly different duties in the two parts of the United Kingdom. Both associations are very well aware of the terrible toll felt by so many involved in the adult social care sector as a result of the pandemic. The two chief executives have filed witness statements, Joanna Killian for the Local Government Association and Chris Llewellyn, who was referred to earlier, for the Welsh Local Government Association. In this short opening, I don't want to reprise the themes that have already begun to become quite clear in the openings that you've heard so far in any great detail, but just to provide a little more context to that which has already been mentioned. First, looking at the position in England, I think the size of the adult social care provision really needs to be seen in a number of different ways. First, the financial side of it has yet to be mentioned. In 2019 to 20 fiscal year, the total core spending of local authorities in England was 46.6 billion. And of that, 37%, about 16.7 billion, was spent on adult social care. That is a huge number, but it doesn't represent the full national cost of adult social care, since much care is self-funded. The figures that the LGA has is about 23.5% of people in accessing domiciliary care are self-funded, and for care home residents, the figure is about 37%, or 137,000 people. You've heard already a little bit about the jobs that are involved in adult social care. The figures we have for England are about 1.65 million jobs, of which about 7 to 8% were vacant. There were about 1.52 million people actually working in the sector. In short, that means there was a gap of some 112,000 people that were needed but were not there when the pandemic struck. 12.3% of those vacancies were in the nursing sector, 8.2% were ordinary, I say ordinary, but non-nursing care worker roles. And you've heard already that this workforce is considerably larger than that of the NHS, some 300,000 more jobs. A little bit more about the statistics. It's an overwhelmingly female workforce, 82%, whereas the national economically active population is about 47%. It's disproportionately older. Some 27% were aged 55 or above, compared to 20% nationally. And it is also very largely brought a very large employer of the BAME workforce. 21% identify as being BAME, against 14% nationally. And of those, it's interesting drilling down to note that 12% identified as black, compared to 3% nationally. And then what about the demand? How does that look in terms of transactions? We don't have the figures exactly for the period during the pandemic, but this will provide, I think, some context for you. In 23 to 24, we know that councils received just under 2.1 million requests for support from new clients, about 0.66 million requests from people aged 18 to 64, and 1.43 million for people over 65. This works out at about 5,700 requests per day, and it was probably considerably larger during the pandemic period. The bare recital of the scope of their duties, the demand, the persons involved, doesn't do full justice to the stress in the sector. As has been noted in other submissions that we've been made, of course, we know that this was a period of very considerable cuts in local government funding. But the LGA wants to say, and to have it heard loud and clear, not only in this hearing, but to the public at large, that the pandemic imposed a huge physical and emotional toll on all those who worked in adult social care because of these stresses. And the consequences can be seen in a number of short points: care provider instability, deleterious impacts on the nature and quality of provision, serious detrimental impacts on recruitment and retention, greater strain on unpaid carers, inadequate investment in prevention, and high levels of unmet and undermet need. One matter, much mentioned today already, but one which we can add a little bit more context to, is what is known in the LGA as the perception problem. This is the perception about adult social care, what it is. And you may find it interesting to know that very shortly before the pandemic, the Local Government Association commissioned a public survey of more than 1,700 people and found that nearly half the respondents had little to no understanding of what social care actually meant. 44% believed social care to be provided by the National Health Service. Over a quarter believed social care was provided free, paid for through national taxation. And finally, I should note on this point that there was so little understanding of this sector that in some cases, those who had interacted with adult social care were not even aware that they had done so. And this perception problem is really important in understanding the way in which this issue has been addressed. With the public so ignorant of what adult social care actually means, notwithstanding the huge demand on it, national politicians have had little incentive to really get to grips with those issues. And you've heard a lot about those issues already, that particular problem. The LGA's role, as I've told you throughout this, was to be the intermediary between its members and government. And in the witness statement of Ms. Killian, you will see much that is discussed on this, and you've already had the Local Government Association's general survey of the local government, of local authorities, which was conducted in conjunction with the inquiry team. Ms. Killian's statement gives some sense of the range of engagement of local authorities. It is, I think, one of the longest statements, over 300 pages long, covering much of the topics that have been mentioned. But I'll just summarise them. Government response, PPE shortages, testing protocols, workforce challenges, vaccination efforts, vaccination as a condition of employment, Care Act easements, grant conditions and funding, data collection and reporting, infection control and testing, PPE, visiting restrictions and impact on recipients. And that's not all. And that will give you some idea of the involvement of the English local authorities, and indeed it's very similar to the position in Wales, to whom I just turn shortly now to add a few more statistics to give you a bit more context of the problems that you will have to deal with over the next 5 weeks of this inquiry. The Welsh Local Government Association statement points out also many of the problems that occurred before the pandemic, noting in particular a growing demand for services due to an ageing population and the increasing complexity of care needs and the strain that just came from that. It mentions also the workforce shortages with significant difficulties in recruitment and retention, with low pay, which has already been mentioned, limited career progression for care workers, and how that contributed to instability in the sector. Of course, also the significant funding challenges and their effect on undermining the sector's stability and effectiveness have been mentioned. Financial sustainability during the pandemic and the role that local government played in that are very important indeed. So adult social care in Wales, like in England, face problems of urgent workforce challenges, recruitment, retention, morale, status, and the need for better progress, all of which created problems during the pandemic when the pressure and stresses were so greatly increased. I want also just to mention the effect, very short.
I'm sorry to interrupt, Mr. Allen. I'm afraid I've allowed you considerably more, given that I thought that maybe the time allotted wasn't exactly generous.
Miss Thomas-Tober said I could have a minute of her time, so will you allow me?
You've already had several minutes. I have to be fair to you, but if you could bring it to a close, I'd be really grateful.
Well, my lady, I wanted to just mention the relative statistics that the Welsh Local Government Association particularly draw to your attention. Between the position of social care workers, the mortality rates in social care, how they were roughly double the mortality rates of those in the NHS, a factor of great importance. My lady, thank you for the time that you give me, and I will rely on my written open statement to contribute to the rest. Thank you.
I'm very grateful, Mr. Allen. I do understand, obviously, given the role of the local authorities, I do understand why there was a certain amount you wanted to put before us. Ms. Stober.
My lady, on this occasion, can you hear me?
Yes.
On this occasion, I represent the Association of Directors of Social Services, referred to as ADAS. ADAS is a charity whose members are current and former local government directors of adult social services and their senior staff in England. ADAS also has a president that is appointed on an annual basis. ADAS is very well aware of the terrible toll felt by so many involved in the adult social care sector as a result of the pandemic, in whatever role. ADAS hopes that this module can do very important work and in its recommendation to ensure better preparation so that this never happens again. My lady, ADAS makes the following important points for the inquiry to take into account in its investigation and in its recommendations. You've already heard, my lady, that social care sector was in a very poor state due to decades of austerity and severely underfunded, misunderstanding and undervaluing of people needing and working in care, a lack of appropriate emergency planning, and significant workforce recruitment and retention issues. A lack of infrastructure and resilience at the beginning of the pandemic led to too few people desperately developing policies, practices, and guidance at too rapid a pace and having to make it up as they went along. There was, again, you've heard, my lady, there was and still is a significant lack of understanding of the complexity and essential nature of social care by the public and by many in the NHS and and central government. Social care was an afterthought before the NHS. Again, this is something we've heard to the inquiry. The focus on prioritising the NHS and maximising capacity in acute hospitals overshadowed people needing and caring, working and needing caring. Rapid discharge from hospitals to care homes without testing, PPE or staffing capacity to provide time for recovery, rehabilitation, re-enablement, and then assessment of people's future care needs had tragic results. There was insufficient consideration of the impact on people with learning disabilities and unpaid carers. National plans were either too late or policies were announced publicly before social care sector was aware of it and able to respond. The need for data quickly meant that local and regional systems were overridden and the use of an NHS system designed for a different purpose. ADAS hope that planning for future pandemics will have greater focus on the social and psychological as well as the clinical vulnerabilities of the population, i.e. the need for both protection and connection. There was insufficient consideration of quality, basic safety and safeguarding in relation to the numbers of people behind closed doors at home or in institutions which effectively became closed institutions with the known associated risks of neglect and abuse. Finally, my lady, the focus on hospitals and a clinical perspective arguably prioritised people of working age, deprioritising those needing and working in social care, and exacerbated inequalities, the impact of which is still being felt today. Thank you, my lady.
Thank you, Ms. Dover. I appreciate what a difficult week this must be for you. My thoughts are with you, all other survivors, and those bereaved by the London bombings on the 5th of July 2005. So please convey my best wishes to everyone.
Thank you,
who's still
lady.
here.
Thank you.
Thank you. Ms. Manahan, I think you're at the back, weren't you? Did I see you? Yep, I did.
For the Department of Health in Northern Ireland. Firstly, the Department would like to place on record its thanks to all of those who supported the delivery of adult social care in Northern Ireland. We recognise that some of the most acute pressures were experienced on the front line, and to that end, the Department would like to acknowledge those in care worker roles. Their dedication in caring for some of the most vulnerable in the most difficult of times is evidence of their commitment and compassion, and we feel must be commended. My lady, I would like to start by briefly summarising the relevant adult social care delivery structures that operated in Northern Ireland. Adult social care services are delivered in Northern Ireland in a mixed economy of care in the statutory sector, the private sector and the voluntary sector. Statutory services are directly provided by the HSE trusts. Private sector organisations and individuals own and run services for a profit. Many of their adult social care services are provided under contract with the HSE trusts. The voluntary sector comprises organisations, some of which are registered as charities, which operate in a non-profit making basis, but who also provide services under contract, again, with the HSE trusts. At the start of the pandemic in Northern Ireland, there were 482 nursing and residential care homes, which approximated to just over 16,000 beds. The challenges faced by the adult social care sector during the pandemic cannot be overestimated. It is accepted that the Northern Ireland social care system was already in a very fragile state by the beginning of 2020, and that provides the backdrop to the sector's response to this pandemic and makes the scale of that response all the more deserving of acknowledgement. My lady, the Department has provided a statement to the inquiry which sets out some of the measures that it put in place to help support the sector in responding to these challenges. These measures included putting in place dedicated plans, guidance and policies for the management of COVID-19 in residential and nursing care homes. However, the Department would like to acknowledge two key points at the outset. One being actions and decisions were often had to be made at pace with the best information available at that time. And secondly, that given the rapidly evolving nature of the pandemic response, it was not possible to engage and consult with all stakeholders to the extent that we otherwise would have wanted to have achieved. My lady, the inquiry today has heard quite a bit about the staffing pressures, which were identified in Northern Ireland as a key challenge for the sector early on. The Department responded to this issue by putting in place arrangements to ensure that the HSE trusts worked in partnership with care home providers to monitor and help deal with staff shortages. In a 6-month period in 2020, the Trust provided over 27,000 hours of staff time to the independent sector that was totally free of charge. The Department understands that no other jurisdiction in the United Kingdom did this. There was similar cooperation evident in the context of PPE supplies for the sector. Recognising the difficulties experienced by the independent sector providers in sourcing PPE, the Department, at a very early stage in March 2020, decided that PPE would be provided to care homes and the independent sector without charge. Alongside this, the Department provided additional funding and investment in the care sector. The full extent of this is detailed in our statement, but there were 3 financial support packages in the single year of 2020, April, June and October, which amounted to approximately £45 million. We also made available enhanced sick pay for both care home and domiciliary care workers. The provision of this sick pay helped to ensure that staff who tested positive for COVID were adequately supported to take the necessary time off work, thereby reducing the risk of transmission to other staff and residents in care homes. The Department also worked closely with the RQIA to utilise their experience in supporting care homes, domiciliary care providers and supported living services. A key outworking of this support was the establishment of the RQIA Service Support Team as an additional mechanism of support for those in that sector. My lady, of course, another topic which this module will deal with is the question of visiting restrictions. The Department acknowledges the very real challenges in managing infection control and balancing that with the need to protect the health and well-being of residents. Whilst restrictions were a necessary protection, the Department also recognises that they undoubtedly impinged on residents' quality of life and the ability of families and others to visit their loved ones. Many significant restrictions were applied, but the Department always aimed to ensure that there was some form of visiting available, even if only virtually. And to that end, my lady, in 2020 and 2021, care homes were provided with funding for the purchase of tablet or communication devices, Wi-Fi coverage was provided, and this was designed to ensure that virtual visits could be facilitated. In September 2020, the Department announced its Care Partner Scheme, which was again another measure to try and alleviate the long-term separation from loved ones. The Care Partner Scheme arrangements were not mandatory, nor were they underpinned by legislation. However, when issues of compliance were identified, the Department worked with the trusts and the PHA to try to maintain contact with care home management to identify solutions and encourage implementation. By September 2020, approximately 60% of care homes had the Care Partner Scheme in place. Another issue, of course, my lady, was the question of discharge from acute hospital settings to a care setting. There were a number of factors which influenced decision-making regarding discharge. Amongst them was the risk of keeping care home residents in hospital longer than was clinically necessary, especially at the time of increasing risk of nosocomial infection. The Department, however, was conscious that the risks associated with discharging residents back to a care home who may have already acquired COVID-19 existed, particularly at a time when testing was so limited. In Northern Ireland, Section 14 of the Coronavirus Act, introduced in March 2020, referred to early discharge. However, I would highlight that this aspect of the Act did not extend to Northern Ireland. Rather, Northern Ireland maintained its policy that discharge of patients was always based on clinical decision-making alone. Testing for COVID-19 was part of a package of comprehensive measures for care homes in Northern Ireland, recommended by the Department from early in the pandemic. The expansion of testing in care homes proceeded in a phased way, based on advice from the initial testing based on those who displayed symptoms, to routine testing of all residents and staff. Another mechanism, of course, for control was the vaccination programme, which began on the 8th of December 2020, and the initial phase of that programme focused on care homes and staff. We have made the point before, my lady, that the JCVI had identified care home residents as a top priority. However, our then Minister of Health determined that they should be the top priority. And COVID vaccinations were delivered to care home residents on the very first day of that programme. By the 26th of February 2021, Northern Ireland again led the UK by having offered all residents and staff in care homes 2 vaccine doses. And at this time, the Department had agreed that trust mobile teams would be redeployed to residential and supported living settings to assist in that programme. Care home workers, again, my lady, were considered a very high priority for vaccination. Although they themselves were not vulnerable to severe disease, they had high exposures and interacted with a high number of the most vulnerable. My lady, in closing, the Department would wish to reiterate that the pandemic required difficult choices, requiring careful balancing of multiple interests, under significant time constraints, and in the midst of immense uncertainty. The Department is acutely aware that these decisions undoubtedly had a profound effect on the population, not least those living and working in the care sector. The Department welcomes the opportunity to provide this opening statement and hopes that, along with all of the other evidence to be submitted to the inquiry, it will help in the consideration of issues pertaining to this module, and we remain committed to the work. Thank you very much, my lady.
Thank you very much indeed, Ms Monahan. Ms Kalik, there you are.
Pryn Houndar. Good afternoon, my lady. I act for the Welsh Government. The inquiry will hear powerful evidence about the impact of the pandemic on the social care sector and families in Wales. It will also hear from witnesses involved in the Welsh Government's response to the pandemic in the social care sector. The Welsh Government welcomes the inquiry's examination and acknowledges that there are key lessons to be learned, both in identifying good practice and recommendations for improvements. I will address in brief 7 particular matters. My lady, you have our written submissions. First, the Welsh Government, as you've heard, is responsible for social care policy, whereas local authorities are responsible for the operational delivery of social services. During the pandemic, existing government infrastructure and systems were supplemented with bespoke groups specifically established to manage the challenges of the pandemic. The Welsh Government also continued to maintain important relationships with external organisations across the sector. Secondly, hospital discharge. On the 15th of April 2020, the decision was made by the Welsh Government that hospital patients should not be discharged into a care home until they had tested negative for COVID-19. This was confirmed in letters to all registered providers and responsible individuals of adult social care services in Wales on the 22nd of April, and to all chief executives of local health boards in Wales, amongst others, on the 24th of April. The Welsh Government guidance followed this on the 29th of April. The Welsh Government acknowledges that in the state of urgency that existed at the time these decisions were made and implemented, that guidance ought to have been published sooner. Thirdly, PPE. The inquiry has heard in previous modules that the provision of appropriate and high-quality PPE was a significant challenge. The pre-existing pandemic stockpile in Wales was supplemented by NHS Wales Shared Services Partnership, which procured and distributed additional PPE on behalf of the Welsh Government. From March 2020, the partnership rapidly expanded its existing NHS-only provision and commenced supply of PPE to local authorities for onward distribution to the social care sector. By March 2022, the partnership issued over 1.3 billion items of PPE to the health and social care sectors in Wales, and around 550 million of these were issued to the social care sector. Nonetheless, the Welsh Government has accepted, as you've heard in Module 5, that the move to centralised NHS-led procurement for the social care sector could have been put in place earlier in March 2020, which might have quickened the improved availability of supplies for the sector in those very early days of the pandemic. Fourthly, testing. On the 2nd of May 2020, the Welsh Government introduced targeted asymptomatic testing in outbreak hotspots and larger care homes which were at greater risk of outbreaks. From the 16th of May 2020, asymptomatic testing in care homes was introduced and made available to all care homes. These decisions were taken in light of the developing knowledge of asymptomatic transmission. The Welsh Government sought to take an evidence-led approach and made decisions based upon the advice and scientific evidence available to it at the time. In December 2020, the Welsh Government published its Coronavirus Control Plan, alert levels in Wales for social care services for adults and children. This plan established clarity in testing arrangements and the ability to foresee testing expectations when alert levels changed. Fifthly, care home visiting restrictions. The Welsh Government sought to carefully balance the need to protect vulnerable care home residents with the need to promote family and social contact and residents' well-being. The Welsh Government produced non-statutory guidance to support providers when making decisions about visits within the legislative restrictions and encouraged providers to respond on a case-by-case basis. This guidance was regularly reviewed and updated in response to the changing level of risk. The Welsh Government also sought to mitigate the impact of visiting restrictions. For example, in November 2020, it introduced the Visiting Pod scheme to support outdoor visits during the winter. Sixthly, the Welsh Government acknowledges the critical role played by the social care workforce and is grateful to staff across the sector for their valuable contributions and service. It took steps to support staff, including via the development of bespoke workplace risk assessment tools, the provision of a wellbeing support line for staff, and the creation of a special payment scheme in which eligible social care staff received a one-off additional payment. The social care workforce responded positively to vaccination, and the minimum thresholds of those vaccinated greatly exceeded those recommended by SAGE, with 92.3% of care home workers having received their first dose by the 16th of July 2021. The Welsh Government also acknowledges the significant role played by unpaid carers. A carer support grant was established, which remains in place today. In addition, the one-off special payment scheme to social care staff was extended to unpaid carers. Seventh, on the regulation of the care sector, Care Inspectorate Wales engaged extensively with stakeholders to ensure that the voice of the sector was heard by policymakers. It adapted its registration process and issued revised guidance during the pandemic. The Welsh Government implemented learning from the first wave of infections promptly. For example, the Care Home Action Plan was developed to address the challenges faced in the first wave. And the Welsh Government also evaluated how policies would affect different groups. It engaged with community groups, stakeholders representing diverse populations, and specific measures were taken. For example, a social care subgroup of the Black, Asian and minority ethnic COVID-19 advisory group was established. Funding was allocated for learning disability health checks, and significant work was done to assist those with dementia, their families and carers. Finally, on funding, the Welsh Government ensured that resources were made available to local authorities to meet changing demands. In April 2020, you've heard that a local government hardship fund was established, which allocated £40 million to help adult social care providers meet the additional costs. In September 2021, £48 million was approved to support a social recovery fund. The Welsh Government regularly evaluated the need to provide additional financial support and how best to ensure that the social care sector met the needs of the Welsh population. Finally, learning and reflection on the part of the Welsh Government took place during the pandemic. Key reports and plans, including a social care recovery framework, were published, and the Welsh Government, my lady, were committed to protecting the Welsh population. It fully supports the need for the inquiry to identify lessons that can be learned and improvements that can be made. My lady, thank you.
Thank you very much indeed, Ms Clegg. Mr Awad.
Thank you, my lady. My lady, I appear today with Miss Vera Withers on behalf of the United Kingdom Health Security Agency, or UKHSA, as we've been referring to it. Your ladyship is very familiar with the work of UKHSA and of its predecessor organisations, particularly Public Health England, and that arises obviously because of our involvement in earlier modules. Today, I want to touch upon how Public Health England and then UKHSA provided support to the adult social care sector during the pandemic, but use my time primarily to focus on 4 themes which bear upon the important question of how the resilience of the sector can be improved for a future pandemic. As your ladyship has heard from counsel to the inquiry, and indeed from other representatives, the structure of the sector is a complex one. In our written opening statement, we set out some reasons for that complexity, but given what your ladyship has heard, I will not repeat those here. Professor Susan Hopkins, Chief Medical Advisor to UKHSA, has provided the corporate witness statement for this module, which sets out the work done by UKHSA and by its predecessors. PHE and then UKHSA had, and has, a discrete role in terms of the support provided to the sector, which can be summarised as first, conducting research into pathogens; secondly, collecting data in relation to outbreaks of infectious diseases, and specifically those in care homes; third, contributing public health advice to guidance owned and published by government departments; fourth, producing guidance in relation to infection prevention and control measures; And finally, providing direct support to care settings and to local partners through regional health protection teams. The corporate witness statement also sets out UKHSA's reflections on the pandemic and what can be done to better support the sector going forward. The following themes can be distilled from those reflections. First, the importance of national to local collaboration. It has been recognised that, certainly in the early stages of the pandemic, there was a lack of strategic oversight from the centre. That changed, and how local and national bodies now collaborate must continue to develop and deepen. In April 2022, UKHSA set up a dedicated adult social care team, which is a permanent function that continues as a source of advice and evidence on public health threats to the sector. As commissioned by the Department of Health and Social Care, this team leads on UKHSA's contribution to national guidance, which is usually published by the department. As our written opening statement, and indeed our corporate witness statement explains, the team engages with the sector in various ways, not only through working with the Department of Health and Social Care, but also by engaging with the Care Quality Commission, the NHS, as well as local government and providers of adult social care. Then they are the regional health protection teams, which I've already mentioned. They are available to provide specialist health protection advice and support. They work with local teams in the NHS and in local authorities, as well as with providers. For UKHSA, the health protection teams are also important, first because they work with the national team to monitor outbreaks and undertake surveillance. And second, because of their involvement in a range of local bodies and because of the relationships they have with, for example, directors of public health. Such participation makes for better information sharing both at local level and back to the centre. My lady, mention of information sharing takes me to the next theme, which is data. It remains the case that there is a lack of comprehensive population and health data at a national level about those who work in the sector and who access its services. And given its role, access to real-time data is obviously beneficial to UKHSA. The more granular the data, the better the understanding of risk across different settings. How we as a country can make best use of data in pandemic preparedness is a point that UKHSA has raised before. The fragmented structure of the sector makes developing a coherent data strategy challenging. However, the UK health data infrastructure is developing rapidly, and a range of data sources now access and use NHS data. There is therefore an opportunity to take a strategic, national approach to the use of data, beginning with care homes as regulated entities. My lady, this is, however, not just about physical infrastructure. During the pandemic, some data systems were set up at pace in response to that emergency, and they may not be appropriate for the next emergency. Reimagining how data is shared and used will depend inevitably on government decisions to funding. But it also raises profound questions about security and privacy, which must be addressed in parallel. Governance and the potential need for statutory regulations are important considerations which are best addressed in peacetime. Our third theme, my lady, is research, and specifically research into the sector. Mention has already been made of the Vivaldi studies, and you will be hearing evidence about those studies. You'll also be familiar with Module 3 with the Easter 6 study. There is a need to improve the evidence base on how non-pharmaceutical interventions, or public health and social measures as they are now termed, can be best used in the sector. Such interventions bring both benefit and harm, and a decision to implement such an intervention is never an easy one. Factors such as the impact of isolation from family, how existing health needs can continue to be met, how non-permanent staff are deployed, need to be given weight. The better the evidence base, the better the guidance, and the more focused the intervention. Our final theme is science. The response to a future pandemic will require a strong domestic science and research base. and the benefits of scientific research are as relevant to the sector as they are to the rest of society. Sustaining our strength in science and research requires not only funding, but the maintenance of international links and collaboration between public and private. Critically, there must be a recognition that encouraging innovation means that not every initiative will immediately succeed, but is nonetheless of value. My lady, you have our written opening statement, and you have the commitment of UKHSA to continue to assist this inquiry with its important work, and those are the submissions on behalf of UKHSA.
Thank you very much indeed, Mr. Hurt. Mr. Mitchell, I think I saw you back there.
Thank you, my lady. This is the opening statement on behalf of the Scottish Government. I appear today along with Junior Counsel Christian Whittaker, and we are instructed by Caroline Beattie and Heather Auld of the Scottish Government Legal Directorate. In this inquiry, it is often said that COVID-19 did not discriminate, yet the Scottish Government recognises that some suffered more than others. Nowhere was this more true than in the adult social care sector. In care homes, families lost loved ones. Carers strove to provide care in often difficult circumstances and were themselves at times exposed to the virus. Some lost their lives. Without hesitation, the Scottish Government acknowledges the profound impact on the sector. It passes its sympathies and condolences to the bereaved. It pays tribute to the workforce and to unpaid carers. Today, we look at aspects of the impact and we explore the rationale behind and the effect of the discharge of patients from hospital into care homes. One of the reasons people in Scotland made so many sacrifices was to protect those most at risk from the worst effects of COVID-19. Scotland's ASC workers, including those providing care in residential, nursing and domiciliary care settings, worked tirelessly to support the most vulnerable. Unpaid carers also faced significant difficulties, as many had to step into the gap to support vulnerable friends and family members during the initial lockdown. And thus, the number of people providing care increased, and many existing carers took on more intensive caring roles, while also losing the opportunity to take breaks from caring. The Scottish Government was aware of the issues and risks that workers faced and sought to protect and to support them. Similarly, it engaged with unpaid carers and representative groups to understand the issues and to provide guidance and support. In addition to IPC, a range of practical well-being and financial measures were put in place from early on in the pandemic. The pandemic adversely impacted end-of-life care in many ways, described in the witness statement of Judith Kilby of Scottish COVID Bereaved. Examples include family members not reaching their loved ones in time for end-of-life visits. The Scottish Government recognises that restrictions on visiting cause much pain and suffering. Yet the complex considerations that surrounded decisions on issues such as visiting are reflected in the findings of the UK CMO technical report, which stated that reducing risk of transmission in care homes involved some of the most complex trade-offs of risk to individuals of any part of the pandemic. It is important to have regard to the actual guidance that was produced by the Scottish Government, in contrast to the measures that individual care homes chose to put in place. For example, the Scottish Government's position from the outset was that essential and end-of-life visits should be supported. As more became known about the virus and protections were put in place, there was agreement on the need for gradual opening of care homes to support well-being. The Scottish Government has taken steps to ensure that people can remain connected to their loved ones, even in outbreak situations. This includes the Care Reform Scotland Bill, approved by the Scottish Parliament earlier this month. Amongst other provisions, it imposes a duty on Scottish ministers to require providers of care home services for adults to facilitate visits. This is known as Anne's Law. Through engagement with disabled people's organisations, the Scottish Government learned of issues and took steps to resolve them. For example, on 28 April of 2020, the Cabinet Secretary for Health and Sport set out details of a range of measures to improve the position for people whose care home packages had been removed. Further, by the end of September 2020, the Scottish Government had made £57.6 million available to support local authorities in ensuring that people were able to access food and essentials. Turning to discharge from hospital into care homes. Background and context have to be considered. To remain longer than necessary in a hospital environment exposes patients, particularly the elderly and those with comorbidities, to risks to their health and well-being. A delayed discharge occurs when a patient, aged 18 years and over and clinically ready for discharge, cannot leave the hospital because they do not have access to the necessary care, support, or accommodation, or funding is not available, for example, to purchase a care home place. In early 2020, two priorities therefore loomed large. First, in light of the expected demand on hospitals, to mobilise and to create capacity within the NHS, and second, to ensure the appropriate, safe and supported discharge of patients for whom hospital was already, and increasingly, a high-risk environment. It should be understood that, in contrast to its relationship with the NHS, the Scottish Government does not have direct statutory responsibility for the delivery of adult social care. It cannot direct providers of social care. It cannot and did not compel care providers to accept admissions from hospitals. The Scottish Government did ask local authorities to put additional effort into reducing delays in discharging those assessed as clinically fit. It would be wrong to suppose that the request presented a stark choice between hospital and a care home. Rather, it recognised the pressures on local health and social care systems of both seeking to prevent avoidable hospital admissions and trying to facilitate the safe and appropriate return home of people who were clinically ready for discharge. Looking at the effect of discharge, we submit there is little evidence that it increased the risk of the introduction of COVID-19 into care homes. Great efforts were made to ensure that the process of discharge was conducted safely. For example, in guidance directed at social distancing, in the need for clinical screening prior to discharge, and in periods of isolation. Further, not all patients were discharged into care homes. Between March and June of 2020, around 63% were discharged back to their own homes, following a period of delay. A report by PHS concluded that no statistically significant association had been found between hospital discharge and the occurrence of a care home outbreak, although a small effect could not be ruled out. By 21st April 2020, testing capacity was sufficient to allow the Cabinet Secretary for Health and Sport to announce in the Scottish Parliament that COVID-19 patients discharged from hospital to care homes should first provide 2 negative tests. Other new admissions should also be tested. Both sets of patients should be isolated for 14 days. Knowledge surrounding asymptomatic transmission had developed. There was a real appreciation within the government, the Scottish Government, as to the vulnerability of the care home population. The aim was to provide maximum support and oversight for a sector largely operated by private sector providers, in relation to which statutory powers of direction were not available. My lady, plainly there is much that could be said about the many issues that the inquiry will explore in this module, but time does not allow today. Those who are interested may read our written opening statement. In conclusion, we finish by again recognising those who suffered and who continue to suffer, and by again paying tribute to those who delivered all forms of social care during the pandemic. Thank you.
Thank you very much indeed, Mr. Mitchell. That completes the oral submissions that I should be hearing today. We've got through a very great deal in our first opening day, and tomorrow we'll start hearing the evidence. And obviously I wish to assure everybody, those who've made oral submissions and those who haven't, that I shall bear very much in mind the contents of all the submissions that have been made, both oral and written. So thank you very much. 10 o'clock tomorrow.